So today, let's briefly look at polycystic ovarian phenotype and see what we can understand from there. So what are the main features of polycystic ovaries? Hyperandrogenism, ovulatory dysfunction, and polycystic morphology. A heterogeneous disorder with various etiologies and a diverse clinical presentation. So you see a huge variation of PCOS. So now the three different diagnostic criteria, the National Institute of Health, NIH, the Rotterdam classification of 2004, and androgen excess and PCOS Society classification. So if you tend to see all the three, there's something there and something not there. So if you look at NIH, hyperandrogenism and ovulatory dysfunction are indispensable features. Rotterdam, two of the three criteria, hyperandrogenism, ovulatory dysfunction, or polycystic ovarian morphology. And androgen excess, hyperandrogenism, is a dispensable feature. So if you see this, there doesn't seem to be much consensus. So in a recent review, when they looked at the overall cardinal features of PCOS, ovulatory dysfunction occurs in about 15%, hirsutism 13%, biochemical and hyperandrogenism 11%, PCOM 28%. If you start looking at ovulatory dysfunction, irregular cycles less than 21 days or 35 days, or less than 8 menstrual cycles a year, PCOS is the most common cause of ovulatory dysfunction. 80% of women with PCOS have ovulatory dysfunction. 40% of hirsute women have, with regular cycles, have subclinical ovulatory dysfunction. If you look at hyperandrogenism, the hirsutism is the main finding of hyperandrogenism. Acne and androgen alopecia is less common. Elevated serum androgen levels are referred as biochemical HA of hypoandrogenemia. So if you look at hirsutism assessed by modified Friedman-Galloway score, or more than 4 to 6, hirsutism present in 80% of hyperandrogenism, and 70% of women with hirsutism have PCOS. If you look at the PCOS morphology, the international PCOS guidelines of more than 20 antral follicles between 2 and 9 millimeter. And as soon as you increase the number of follicles, PCOM decreased from 36.5 to 12.5. Combining AMH and PCOM may help in reaching this diagnosis. So let's look at the prevalence. By the NIH criteria, 5 to 10% of PCOS. Rotterdam, 2 to 21%, and the androgen excess PCOS is between 2 and 17%. Considering all the criteria, it's between 6 and 10%. So as soon as you increase the number of antral follicles to 20, then 19.9 to 10% of the Rotterdam classification would be PCOS, and 15.3 to 8% would be from the androgen excess. And so by increasing the number of follicles, you are decreasing the prevalence of the syndrome by 40 to 50%. So let's now look at the phenotype in a much better way of classification. And if you look at the phenotype, phenotype A is hyperandrogenism plus ovulatory dysfunction plus polycystic ovarian morphology. So if you look at the referral population, they form the bulk of the referral population at 53%. Of the unselected, they seem to be the 19%. If you look at phenotype B, which is hyperandrogenism plus ovulatory dysfunction, no polycystic ovaries, that's of a referral around 14%, in the population about a quarter. If you look at type C, where you see hyperandrogenism, regular periods, and PCOM morphology, you're looking at a referral population of around 15% by a study, but overall you're looking at a much larger population in the general population. And phenotype D is where you see irregular periods with PCO morphology, but androgens are normal. So, let's go back and look at the classic PCOS. Type A and type B are classic PCOS. More hirsute and obese, more likely to have insulin resistance and increased risk of metabolic syndrome. They're referred to as classic PCOS. Phenotype C is where you have no ovulatory dysfunction, you have hyperandrogenism with PCO-looking ovaries. We call that ovulatory PCOS. And the risk of metabolic syndrome is less than A or B. If you look at type D, its phenotype D is ovulatory dysfunction with PCON without hyperandrogenism, normal androgens. It's a milder degree of ovulatory dysfunction, the mildest degree of endocrine dysfunction, including metabolic syndrome. So if you look at the distribution of PCOS, if you look at A, again, as I said, the largest group will be A. So A and B are the more serious and the more commonly seen one. So if you have a look at the conclusion, and let's look at type A is the commonest presentation, type C is the commonest in the unselected population in 1 and 3. Type A and type B are more likely to be severe phenotypes, more clinical and biochemical HA. It makes it easier to understand PCOS when you look at the phenotype, making classification better, making treatments much better, and understanding PCOS much better.